Bismillahirrahmanirrahim. Assalamu alaikum and good morning, ladies and gentlemen. I am Dr. Shamsa Humayun, Professor and Head of Obstetrics and Gynecology Department at Fatima Medical University, Lahore. I am also working as Director, Department of Medical Education and Dean Faculty of Surgery and Allied at Fatima Medical University. I am honored and privileged to be part of this cancer awareness program. Today, I am going to talk about uterine cancer or cancer of the body of the uterus. Uterus has three layers. The innermost layer is also called endometrium, middle layer is myometrium, and outer layer or serosal layer. As this tumor rises from the innermost lining of the uterus, which is endometrium, so it is also called carcinoma of the endometrium. Ladies and gentlemen, this tumor is slow growing tumor. The incidence is rising. In USA, the reported incidence is 2.8%, while in Pakistan, this is the third most common malignancy in women who present with us with genital tract tumor. The rising incidence is probably we are seeing more due to increased life expectancy and due to certain other reasons. There are certain women who are more at risk of developing uterine or endometrial cancer. The risk factors are women having less number of children, having no children, they are obese, then they have early age of menarche, late age of menopause, polycystic ovarian disease, using hormone replacement therapy for a certain number of years, with the family history of genital tract tumor, past history of breast cancer. So all these patients or all these women, they are at high risk, but it does not mean that they are definitely going to develop uterine cancer. This cancer can involve younger age, like in perimenopausal age group as well. So one should keep in mind the all age groups and must pay attention to the signs and symptoms. So what are the signs and symptoms? Patients usually present with postmenopausal bleeding or bleeding once they have stopped menstruation around about age of 50. Any amount of bleeding, small, moderate, or severe, should be taken very, very seriously. Abnormal vaginal discharge, which can be foul smelling, which can be blood stained, which can be pussy. Then pelvic pain, pressure, and in perimenopausal age group, this can be heavy irregular vaginal bleeding, abnormal discharge, and pain. So once a patient comes with these signs and symptoms, she needs to be examined and then investigations are planned. The investigations which usually are advised, the ultrasound, which can be transvaginal ultrasound or pelvic ultrasound, and in view of that, further investigations can be planned like MRI or magnetic resonance imaging. The normal cutoff value which a sonologist can give you after menopause, the thickness of endometrium is 3 to 5 mm. Anything more than that needs further evaluation. So the next evaluation is in the form of obtaining the endometrial sample or the strip of endometrium for laboratory confirmation. So how this strip can be obtained? Can be an office procedure where endometrial sampler can be used to obtain the endometrial tissue, or in some cases where cervix is stenosed, then dilatation and curettage under anesthesia or hysteroscopic directed biopsy is advised. In 90% of cases, the report comes back endometrioid adenocarcinoma, which is more localized, well differentiated, and have good prognosis. In certain cases, the report can be clear cell tumor or some other like papillary cell tumor. So there can be different histopathology diagnosis. But usually these tumors have poor prognosis and early spread beyond uterus. Once histopathology is obtained, then it is important to stage the disease and grade the disease. Staging is usually done at surgery and with certain investigations, depending upon how much tumor has involved the other layers of the uterus or surrounding structures like vagina, bladder, rectum. So once staging is done, the treatment options are given to the patient. The treatment options, the number one is surgery is preferable option if it's a localized disease, that is in the form of total abdominal hysterectomy and bilateral salpingo-oophorectomy. At times, in certain number of patients, lymph node dissection is also required, but this is the decision of the surgeon and oncologist. They make this decision in collaboration and they discuss. As far as prognosis is concerned, the prognosis is good. Mostly in early stage disease, surgery is sufficient, but again, in some cases, later on, radiotherapy can be advised, or in inoperable cases, chemotherapy may be required. For all stages, 5-year survival is good. It's almost more than 90% in stage 1, more than or equal to 90% in stage 2, and till stage 3, it is 60% and beyond. So, if I summarize, this endometrial or uterine cancer has good prognosis. It is slow growing, usually limited to the uterus, and presents with abnormal uterine bleeding, abnormal discharge, and one should not ignore those symptoms. Must consult their healthcare provider who can advise what to do next. Thank you. I hope that message is conveyed and it will be helpful. Thank you so much.